State Chapter, and welcome to the continuing education program from ISA Kerala State Chapter. I'm really honored to welcome our guests of today because we have all the stalwarts in the field, and we are very happy to mention that all the academic programs of ISA Kerala State Chapter is keeping high standards and is well attended both by the youngsters and the senior members. Today we have two topics. One is advanced hemodynamic monitoring in renal transplant. And the speaker for this topic is Dr. Vinodan K, who is heading the Department of Anesthesia at Medical Trust Hospital, Cochin, Kerala. He is our own member, very active member, and a well-known faculty all over the country. Sir, I am really honored and happy to welcome you to this meeting, Dr. Vinodan K. The second topic is really a new topic, which we are all awaiting. What is the content of that? The intraoperative hypotension and artificial intelligence. To highlight this topic, we have Dr. Sangeeta Khanna, who is the Director, Institute of Critical Care and Anesthesiology, Medanta, the Medicity, Gurugram. Madam, I am really proud and honored to welcome you to the state of Kerala and welcome you to this meeting. This session will be chaired by Dr. J.V. Divatia, who is a professor and HOD of Department of Anesthesia and Critical Care, Tata Memorial Hospital, Mumbai, a well-known speaker and a well-known faculty and excellent administrator. Sir, I'm really happy to welcome you to this meeting, Dr. J.V. Divatia. The second chairperson for today's meeting is Dr. E.K. Ramdas, who is heading the Department of Anesthesia at Baby Memorial Hospital, Calicut. He is actually my own teacher who taught me the basics of anesthesia. I am really honored to welcome you, sir, to this meeting. I take this opportunity to welcome all our senior members, our National President-elect, Dr. Venkatagiri, our Honorable Secretary, Dr. Bill Isaac Matthew, and all other faculties who joined us to this meeting, and also the delegates. Once again, I welcome you all. Thank you all. Now over to Dr. Venkatagiri, ISA National President-elect, for a few words. Dr. Giri, please.
Good evening, President Dr. Nazar, Secretary Binil. Today's faculty is Dr. Vinodan and Sangeeta, chairpersons Dr. Divetia and Ramdas, and all delegates, friends, everybody. It's happy that ISA Kerala webinars are going strong with the good faculties, and as Divetia just told how popular our CMEs and webinars are, and even his daughter appreciated and told that because of our webinar could answer all the questions easily. She's also MD anesthetist. So it is very difficult for us to keep this high standard and keep the faculties, chairpersons and all. When this new topic, Vinil asked Giri sir who should be the chairpersons for this. We had no other thinking other than Dr. Divetia and Ramdas. Because when a new topic and discussion, we should have people with the knowledge and able to carry that. So we are happy that both of them have agreed and come there. I welcome all of you and wish that we will have the similar webinars with high standards every month or bi-weekly. Also, we should see that the PGs also attend these webinars, which are by good faculties from all over India. So with this, I conclude and wish all the best. And all the delegates, they have a lot of people came from other parts also. Dr. Surendra Sharma is there. Dr. Aikwar is there. Then Vishwanath Hiremed. There are people from all over India. Welcome every one of you for this webinar. Thank you. Over to you, President.
Now we'll move on to academic session. Vinil? We'll move on to the academic session.
All the moderators for introducing speakers.
Can I start? The chairpersons, Dr. J.V. Divadia and Dr. E.K. Ramdas, to introduce the first speaker. Sir, chairpersons, please.
Yeah, I'll start off then. To start off, I must thank ISA Kerala State for this invite. I'm extremely happy to be part of this webinar. To start off, again, to introduce the first speaker, all of you must be very familiar with Dr. Vinod, and we have been seeing him for the last several years. He has an experience of 45 years in the field of anesthesia. He is heading the Department of Anesthesia at Medical Trust Hospital, Cochin. The first successful renal transplant was done in 1986 in Kerala by Dr. Vinodan. First cadaver transplant after 10 years after that, and the first heart transplant in 2003. And he has an experience of more than 3,000 renal transplants. And he's an apt person to talk on this subject. And more than that, he's a good friend of mine. I'm really proud of him, and I introduce him here. And over to Dr. Vinodan.
Sir, please share the screen.
Is it okay? Yeah. He's getting connected.
Vinodan sir, please unmute and share, sir.
Yeah, am I audible now?
Yes, you are audible.
Yes, sir. Now you are audible, sir.
Okay, so I'll start
Please share
over
the screen,
again.
sir.
Thank you very much, ISA Kerala, and thank you, the chairman, for introducing me. It's nice to see all those new smiling faces, old friends. I mean, we meet now through this virtual webinars, and that's the only way we can meet now. But it's really great. ISA Kerala is doing such a great work. It's appreciated by everyone. All the students appreciate it. I think you continue this for a long time till we can meet after the corona departs. Thank you, Ramdas, for introducing me. It's a privilege to have two chairmen, one Dr. Divatia and Dr. Ramdas, both have tremendous experience in the topic that I'm going to talk about. Shall I start sharing my screen?
Yeah, please share the screen, sir. It's visible, sir. Yeah.
It's okay? Right.
Yes, sir. Perfect. Please go ahead, sir.
So the topic I'm going to talk about is the monitoring in renal transplant patients. Monitoring is something that we all know is one of the most important things that we have to perform during the perioperative phase, and that's what actually makes sure that your patients go to the ICU and back home without any problems. So it's a very important part of anesthesia. And in the early days, when we started transplant, let's forget about even before that, what we had was just some hardly any monitoring. We had even the time when I had my MD days in JIPMER, we had only this kind of monitor. I mean, one small monitor which had only cathode ray oscilloscope. You have to really look into it carefully to see whether the patient's heartbeat is there or not. You can just about see the monitor beeping and the the pulse wave or the ECG coming and going. And even that in that time in Japan, that is in 70s, only the cardiothoracic OT had this. And even that was very difficult for all of us to see. We couldn't actually decipher what is happening there. To the extent that the cardiac surgeon actually used to employ a ECG technician to be sitting in front of it and shouting what is happening. So the fellow used to shout, sinus, 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 VPC, VPC, sinus, sinus. And that is the way we actually monitored in those times the heartbeats. But from that, in about early 80s and late 70s, we got the other monitor that I've shown you, the memory monitors, which actually could capture the ECG and show it for at least for about 5-10 seconds so that you could see. It was supposed to be a real giant leap in monitoring at that particular time. But we even when I joined Medical Trust Hospital in 1979, we had only few of these memory monitors, and all except in cardiac surgery cases, it used to be the CVP was measured with a water manometer, and there was no invasive BP other than in cardiac surgery, and mostly the static parameters, which we know are highly unreliable, were the only thing which are actually monitored. But in 90s, yes, we had a giant leap by the fact that we got the pulse oximeters, and we started having monitors which can actually monitor arterial blood pressure, CVP, pulmonary artery wedge pressures, and also we got the echoes. But now it's a different story. Even the theater that I do renal transplant, what we have is a monitor like this, and then we got the large monitors which tells you so many things. We have the hemodynamic and static variables, and we have a monitor giving the ventilative variables and also the dynamic variables. Probably about 50 parameters being monitored or every second and minute, and then that's something that gives you an in-depth into the patient's hemodynamic as well as the respiratory variables. But coming back to renal transplant patients, they do these really need this monitoring because they are actually as a grade 3 patients. They are uremic, anemic, hypertensive most of the time, and they have evidence of myocardial ischemia, uremic cardiomyopathy, valvular regurgitations, mainly the tricuspid as well as the mitral regurg, and sometimes the pericardial effusion going on to even a tamponade status. There, most of them, a large number of them, especially what we see in Kerala, are diabetic and with associated metabolic and vascular diseases. They have cerebrovascular diseases and coagulation disorders. So all these patients actually need very good amount of optimization as far as possible so that they can go through the surgery and come out with flying colors. So what is important is the perioperative optimization, which is where good hemodynamic as well as monitoring all these parameters actually help you. What perioperative fluid and hemodynamic optimization actually means is to make them ready for the surgery as well as the metabolic as well as respiratory and cardiovascular insult that they can undergo during this period. So you need to give them right kind of fluid in appropriate amount and at the right time. And to know this, you have to monitor their hemodynamics well. And you have to optimize the circulatory system to ensure that sufficient delivery of oxygen to organs takes place. But remember, you cannot have a universal regimen for optimizing fluid management because it is difficult, mainly because the response to this therapy, the fluid therapy, varies between one individual to another individual. So you have to individualize. Remember that one size does not fit all. So you have to individualize and then make sure that give them the right amount of treatment, right amount of fluid during the surgery. So what you have to do, that is, you have what hemodynamic optimization that you have to do should be actually according to the fluid responsiveness, and to measure that you cannot have static parameters, which has been shown to, in many studies, which has been shown to be unreliable. So always use available variable for fluid responsiveness and left ventricular out variables, and that is the ones that I'm going to talk about in this lecture. And fluids should be given when you find that there is fluid responsiveness, and the fluid responsiveness is adequately demonstrated, and global tissue perfusion surrogates like lactate have not been normalized. In patients, you monitor many factors affecting hemodynamic conditions. Of this, the more important ones are the intravascular volume. And intravascular volume is something that's very important in renal transplant patients because They can come to you in various stages. They may come with a normal euvolemic state, but many times they may have in a hypovolemic stage because they must have had a large amount of fluid removal, a long hemodialysis, and sometimes the hemodialysis was done long back, like in a patient who comes to you in the middle of the night for a cadaver transplantation. He probably had a dialysis done about 3 days back and didn't get enough time to optimize or dialyze. So he may come with almost in pulmonary edema. So the intravascular volume assessment is very important. You also have to know that the myocardial contractility is good. You can have probably a previous echo study, but then during the surgery, you should actually monitor the hemodynamics well enough to know that the stroke volume is sufficient, cardiac output is sufficient. You may have to also monitor the myocardial ischemia and monitor heart rate and rhythm. Another important aspect is the afterload, the vasoactivity of the patient. That also has to be taken into account so that you know whether the SVR is high or low, and you have to give the drugs according to that. So to ensure an early graft function, you have to optimize. And the goal is to achieve values for very good, the best values for perfusion and oxygen delivery. If you look at that the graph, you know that the perioperative morbidity risk comes to the lowest when fluid is optimized. And that happens when you keep the fluid dot slightly on the positive side. So to do this, you need a perioperative goal-directed therapy. And the most important part of that is to optimize the stroke volume, to optimize the preload, the contractility, and the afterload. A little digression from this to tell you something different, that is the Guytonian theory of circulation. So that only if you know a little bit about this, or if you can read up, most of it, especially for the postgraduates. I think you should read up about Guytonian theory of circulation. It gives you a better insight into how to look at these variables that I'm going to talk about, because they depend on the venous return and the importance of the venous side of the circulation. The venous return is proportional to the pressure gradient of the venous return. That's called as DVR, and it is inversely related to the resistance to the venous return, that is the RVR. And DVR is defined by the pressure difference between the right atrial pressure and the mean systemic filling pressure. That's called the PMSF, which is something that you should look up. It's something that is very important in this Guytonian theory of circulation. It's the mean pressure in the CVS when there is no blood flow. So you look at a patient who is almost having no cardiac output. In the lower part, that x-axis is where absolutely no cardiac output is there. And at that time, the volume status gives you a mean systemic filling pressure, which is something that earlier was proposed, but only in the recent studies they've been able to measure that and show that it's around 15 to 20 millimeters of mercury. And that is the pressure which is there in the circulation without any cardiac effort at all. So that increases as the cardiac activity increases, and that is what you're going to measure. That is what you measure, and then that depends on the stress volume and the mean compliance of the vascular volume. That is what is going to increase the venous return. So this stress volume is about 30% of the intravascular volume. That stretches the vascular wall and generates pressure, and that increases the venous return. And optimizing preload, which is what we do, increases the stress volume, increases the PMSF, that is the mean pressure in the circulation, and increases the DVR, that is the differential of the venous return, and thus also raises the venous return. And RAP, if you look at this, RAP has nothing to do with this. That is the CVP or RAP that you usually measure. It has nothing to do with this. Actually, it is a result of all these changes that you get the RAP or the CVP. That is why CVP is something that is not an important criteria as far as optimization is concerned. So if you want to learn more about it, please, the postgraduates, please read up the Guide and Model of Circulation. There are many new articles which have come. You should all read, take care and read this. It gives you a better insight. And then you also looking at the volume responsiveness, and that is looking at the increase in the stroke volume of cardiac output when you give them a fluid bolus. If you give a fluid bolus and then you find that there is an increase in the stroke volume of cardiac output, you know this patient can be given more fluid and he is responsive. That doesn't mean that you have to give fluid unless you need it, but then you know that if you give fluid, this cardiac output as well as stroke volume will go off. So that is looking at the Starling's ventricular function curve, which has got, a steep portion and a portion which is flat. The stroke volume increases in the steep portion as you increase the ventricular preload. So you increase the ventricular preload in the steep portion, actually you will find that the stroke volume increases. But once it reaches the upper part, that is the flat portion, any more preload, the stroke volume does not increase. So if you reach that area, there's no point in further giving volume. It will only produce more problems and no improvement in the stroke volume. How do you measure this? You measure this by looking at the changes in the left ventricular output, that is the stroke volume or the pulse, during IPPR on a patient who is ventilated, who is being paralyzed. So in this, if you look at it, you will see that you have a wave of the ventilation. This is the ventricular pressure rising up and falling. It's the inspiration, this is the expiration. Okay. When you look at it, you will find that when the inspiration takes place, initially the left ventricular output increases. This is mainly because the ventilation produces a pressure increase in the lungs, and that will actually push the pulmonary circulation fluid into the right atrium and into the left atrium and into the left ventricle, increase the end diastolic volume of the left ventricle, increase the output. Now, what happens at the same time, the right ventricle does not get enough venous return because the right ventricular pressure increases, the venous return comes down, right ventricular filling comes down, and 2-3 beats of right ventricle, you will find that the right ventricular volume which is going into the left ventricle comes down. So the left ventricular filling comes down, and you will find slowly the left ventricular pressure, left ventricular stroke volume as well as the pulse volume comes down. So it comes down. Then towards the end of the expiration, you will find that it comes to the lowest. Now, this is the highest peak and this is the lowest peak. So if you look at the maximum, that is the SV maximum which is here and the SV minimum which is here, you find the difference between this and divide that by the mean stroke volume that you have, multiply by 100, you get the percentage of the change of the stroke volume. That is the stroke volume variation, SVV. And if it is more than 10, it means that this patient can be given fluid. Doesn't mean that you have to give them fluid. It means that you can give them fluid, and then that will actually improve the stroke volume in case there is a reduction in the stroke volume. This is the same thing. You see this, the minimum, this is the maximum, and from between the maximum and minimum you find out, and then divide by the SV mean and multiply by 100, you get the percentage. You can also, it also calculates the stroke volume. Looking at this, so if you see the level from, this is the diastolic dicrotic notch, and this area under the curve is calculated. That gives you the stroke volume. It's an approximate value of the stroke volume that you get, and that is what you get in the monitoring screen. So you measure the stroke volume, you also get the stroke volume variation, which gives you the responsiveness. This is, remember, applicable only when you mechanically ventilate this patient and they have a regular sinus heart rhythm. That's what you see on the screen of the monitor. You see the cardiac index, or you can get the stroke volume index. You also see the stroke volume variation. The same thing is possible in different monitors where we monitor the pulse pressure variation, and that is the same way. This is the pulse pressure which is monitored. This is the maximum, this is the minimum. Then again, from maximum to minimum, you get the what is the variation, and that is divided by the pulse pressure mean, and you get the pulse pressure variation. You can also monitor in some of the new monitors without any of this. If you have the arterial wave, from that you can see the change in the systolic pressure. This is the highest systolic pressure. This is the lowest systolic pressure, and you see the difference between the the higher systolic pressure and the lowest systolic pressure. Again, you can calculate the systolic pressure variation, and that is called the SPV. Or in your plethysmographic wave, you can measure the plethysmographic variability index. All this gives you the fluid responsiveness. This is the SPV in the monitor. Same way, this is the highest systolic, this is the lowest systolic. You see the difference, and then you know the SPV is 10 in this. Okay. So these are the various things that you can do to get the volume responsiveness, and that is the kind of monitoring that we have in these patients, and then that helps us in giving the correct amount of volume and the correct time preoperatively or perioperatively or in the early part of your operation. You have to know that there are many things that can give you the volume responsiveness, of which patient on mechanical ventilation with a sinus rhythm who is paralyzed, you can use either this PPV, SPV, PVI, or SVV. All of them can be. These the values that is taken as the higher than 12% of PPV, SPV, PVI shows that the patient is responsive, whereas SPV more than 10% means that patient is responsive. You can also use PLR maneuver. Obviously, you can't do that in a patient undergoing renal transplantation. But in a patient who is having spontaneous effort, or a patient who is having spontaneous breathing, then PLR maneuver is probably one of the best that you can do. So you can do it in a patient who is in the ICU. You can also check the RAP changes during inspiration. You can look at the arterial pressure changes during a valvular maneuver. You can also check the IVC collapsibility index. In a patient with the arrhythmia and spontaneous breathing, only PLR maneuver can be done. In case you have nothing, we have to go back to the old method, that is looking at a fluid challenge and finding out the changes in the blood pressure. So the factors that we talked about, you look at the intravascular volume, you look to find out the intravascular volume, you look at the preload variables, SVV, the PPV, and the SPV. That tells you whether the intravascular volume is adequate, whether the patient has got adequate volume, and whether the patient can be given more volume. You can look at the myocardial contractility by monitoring the stroke volume, cardiac output, and cardiac index or stroke volume index. And also, some of the monitors can give you the dP by dt. That is the steep portion of your the pressure wave, the arterial pressure wave, how fast it goes up. That is the dP by dt. That also gives you an index of the myocardial contractility. The vasoactiveness you measure by looking at the SVR and SVRI or the PVR. Again, this can be calculated very easily if you know the stroke volume or cardiac output. If you find out what is the mean arterial pressure and find out what is a RAP or the central venous pressure, you find the difference between the mean arterial pressure minus the CVP, divide it with cardiac output, you get the, and multiply it by 80, you get the SVR. This is something that can be easily done, but most of the monitors will give you this derived values. Straight away you enter this and then you get the values very easily. And looking at that, this SVR, like this patient has got a very low SVR, you know this patient needs a little bit of vasoconstrictors, you can give them vasoconstrictors. So why do we need dynamic variables? Mainly, as I told you, the static variables are sometimes misleading, so it's very difficult to actually look at them and then say that whether this patient needs fluid or not. Like a patient who comes with transplant, renal transplant, you find that most of them have a little bit of tricuspid regurgitation, sometimes really bad, and you will find that their central venous pressure, if you monitor CVP, will be always about 20 or even above. I had quite a few patients who had actually CVP of more than which was shown as more than 35, more than 40, mainly because they had a roaring tricuspid regurgitation. So you cannot give them any fluid if you look at that. They may not, you will be thinking of actually taking them back for another dialysis before taking up. So it's actually misleading variable. And as I showed you in that the theory of Guyton, they actually monitor the results of the dynamic changes in the CVS. They are not what actually produces the dynamic changes. These are actually a result of the dynamic changes. So you want to see what are the variables which produce the dynamic changes and not the result. So you have to have the dynamic variables and flow variable monitor, and the fluid administration should be done with that. And then you find that actually in the transplantation or even major surgery, the amount of fluid that you administer is actually less. You have to give only very less amount to get the right amount of dynamic variables and flow variables. And this makes sure that you have patients with better hemodynamic stability. And there are quite a bit of recent evidence to show this, but two recent evidence which has come out, the perioperative goal-directed therapy during kidney transplantation, which is an impact evaluation by Marco Cavalry. It came in January 2019 and showed that actually significantly less intravenous fluid administration was necessary in this patient, and significantly less incidence of early graft dysfunction occurred in these patients. A similar control study was done by Alessandro, Italian authors, who actually this was published in Brazilian Journal of Anesthesiology in 2020, and they actually used pulse pressure variation, and the other people actually used stroke volume variation. So one reason why we do this in renal transplantation, of course, looking at the delayed graft function in these patients to avoid the delayed graft function. But remember, hemodynamic instability is one of the reason for delayed graft function. It may be because donor-related factors, it may be recipient-related factors, it may be surgery-related factors, it may be due to an ischemia time, it may be due to the ischemic reperfusion injury, it may be because of immunological issues. But we have shown that looking after the hemodynamic instability, monitor them adequately, optimize them with dynamic variables, we get a fairly good reduction in the delayed graft function in this patient. There are also some definite reports showing that goal-directed fluid therapy using dynamic variables actually improves even in other surgeries. It increases or reduces the ICU readmission in ICU, and earlier return of bowel function and lower incidence of PANV and shorter length of hospital stay in gastro patients, significantly shorter length of hospital stay in again in GI patients, and decreased mobility in most of the large surgeries. In renal transplantation, they have shown that postoperative acute renal injury again is significantly reduced. Occurrence of renal dysfunction was reduced, and mortality was also significantly reduced. Remember, when you do this, the 5 T's in perioperative goal-directed hemodynamic therapy, you should actually select the right patient, select the high-risk patients when you look at them. That is the patients who are actually, I don't know whether you can see it well, you should look at patients who have high surgical risk, and patient who's got a patient risk is also high. So that is the kind of patients you should be looking at. And then the timing of intervention, actually, the timing should be, you should start the monitoring early, and make sure the volume responsiveness is found out early and then treated early. And the intervention should be a combination of fluid, vasopressors, and inotropes, depending on what variables, what are the results of the variables that you see, and you should look at giving more fluids or vasopressors or inotropes. And the target variables are mainly the stroke volume variation, the pulse pressure variation, the stroke volume and the stroke volume index, cardiac output and cardiac index. These are actually dynamic cardiac preload variables and the flow related output variables. And the target value, as I told you, is usually 12% for most of the cardiac preload variables, and less than more than 10% in the stroke volume variables. But remember, there's always a gray area in this, like area, like, you know, if you take SVV, the stroke volume variation, above 12, you are sure that definitely this patient is volume dependent, but at around 10, it's very difficult to say whether they are nursing. Similarly, when it goes below 8, you know that this patient doesn't require any more fluid, but above 8, you are still not sure. So 8 to 10 is a gray area. So you should use your clinical acumen there and then make sure that you give the patient the benefit, true benefit from this monitoring. So summing up, there is substantial evidence that preoperative GDT protocolized hemodynamic optimization strategy for titration of fluid, vasopressor, and inotropes to predefined target values of hemodynamic variables definitely improves postoperative patient-centered outcomes. And remember, no monitor is therapeutic in itself, but it requires the skill and vigilance of a trained observer to interpret the information in the context of ever-changing clinical picture. So thank you very much for your patient listening. Thank you, ISA Kerala.
Thank you, Dr. Vinodhan, for that informative talk. Can you hear me? Can you all hear me? Hello?
Yes, we can.
Yeah.
Yes, sir, we can hear you. You can hear you.
Yeah. Dr. Vinodhan, just I'll start off with some I have some comments on this topic. See, there are currently we do not have a recommendation for hemodynamic monitoring, hemodynamic targets during kidney transplantation. And we all, including me, we used to rely, not now, we used to rely on empiric and obsolete parameters such as central venous pressure, and we look at the dry weight the previous day dialysis, before dialysis and after dialysis, and then calculate the fluid that is required. How about doing that? When you do not have all these parameters, monitors, how good they are in the management of transplant patients during the perioperative period?
Yeah, I do agree that when you don't have these variables, you don't have anything to look at. But follow this thing, because even earlier, before 2000, I used to follow the same. So we had the static variables, and the usual dictum which used to be given was that you bring it up above 8 CVP of 8 millimeters of mercury, and you can go up to even 50 millimeters of mercury to get the best output at the time the clamp is released. That used to be the what is taught, what is available even in the textbook, even in some of the textbook even now. The reason is that that is only available monitoring we had, and that we always look at doing the best that we know, best that is available to us, and that is probably the best way of doing when you don't have this. But when you have this kind of variables available to you, it is possible for you to give small doses of small aliquots of fluid, like you can give about 200 ml of 500 ml maximum. 200 ml is enough for you to find out what is the way the volume responsiveness goes, and then that way you can limit the amount of fluid to bring up the best scenario as far as the patient's hemodynamic stability is concerned. That is one thing that has happened. The amount of fluid that I used to use in years before 2000 used to be almost double of what I used now. That is one thing. Secondly, we always used to doubt, is this correct? Because as I told you, some of the patients come with a CVP of 18, 20, then what do you do? So you have to actually go by the fact that when you give fluids, of course, yes, they do better. So you have to bank on a slightly higher your value. If you start with 18, you have to, okay, I'll go up to 20. That will be the only way you can go. And you don't know whether you're doing harm or whether you're doing the right thing. That is the problem is. So this gives you a method to know that what you're doing is probably the right thing.
Probably esophageal echocardiography would help in optimizing fluid management. I don't know. We don't use it in our institution.
The thing is that echocardiography is something that you can do repeatedly at intervals, or you can probably give a volume and then change the thing. Same thing that you do in PAOP. But these are variables that gives you every 30 seconds it changes. So the value is refreshed every 30 seconds. So as you give each ml, you know what is happening. That way these variables actually help you. So even before anything happens. Other thing you get to know when you're given already 200 cc. This as you give 50 ml, you know whether so you can start with a smaller amount and then go up on it and then look at it as it goes. That is the good thing about it.
There is a question from Veena, Dr. Veena. She wanted to enumerate some static parameters to monitor in absence of dynamic monitoring devices. I think you have already said that, I think.
Yeah, I think whatever is available was central venous pressure, pulmonary artery catheters, and then giving you all those values. So,
yeah, she has also asked about ultrasound, in monitoring some parameters. And ultrasound,
the
I don't know.
ultrasound monitors, you can monitor the venous collapsibility index, but again, there are some question marks being asked whether they are the right thing, and then there can be changes due to various other things happening during the procedures.
Okay, thank you, Dr. Vinod. And there are, your talk was great. The response from the audience. Okay, thanks a lot. Thanks a lot for this. Any more questions and anything from the audience?
Sir, audience, we will not unmute now.
Okay,
At the end
chatting.
of the session, we will allow them to understand us.
No, chat,
They
that is all.
can
That is all.
chat now.
Yeah, that is all in the chat. That is all in the chat. Thank you.
Thank you very much.
Yeah.
Thank you, sir. We can move on to the next session. Over to Divadya, sir, for introducing the next speaker.
Good evening. It's my pleasure to be a part of this meeting organized by ISA Kerala. I think you're doing a wonderful job with these weekly sessions. It is my pleasure to introduce the next speaker, Dr. Sangeeta Khanna. She's the Director of Anesthesia at the Medanta Medicity in Gurugram. She's an extremely experienced anesthetist and a very good speaker. She specializes in robotic and thoracic anesthesia and renal transplant. And she's been the past president of ISA Haryana and has got many publications and been very active in the ISA. And she will be speaking on a very, very interesting topic on artificial intelligence and hypotension during anesthesia. I think it's one of the new things which is coming up. And I know she has done some work on this and she's trained on this. So I'm looking forward to hearing Dr. Sangeeta Khanna. Madam, please.
Yeah, okay. Thank you, Dr. Divatya, for that generous introduction. Can you all hear me?
Yes.
Carry on, ma'am.
Yeah, okay. So I would like to, at the outset, thank ISA Kerala for giving me this opportunity. And I think it was an interesting talk which we heard from Dr. Vinodhan. And if we continue on the same lines, I think over the last few years, what we have all seen is that, we have a lot of articles and publications coming on. We are happy with providing good quality of anesthesia, but more than that, I think what we are looking at is the post-operative outcomes, that we want, that there is no organ dysfunction, no major organ dysfunction. The patient goes home walking, he's able to ambulate soon, he's able to resume work soon. So when we look at all these articles and we have looked at all these publications, we have found that one most important parameter which is responsible for giving us this good outcome is our blood pressure. And what we see is that, when we are awake and moving around, we do not have these fluctuations in blood pressure as we have, when the patient gets anesthetized. And this is basically because of the loss, or we can say the altered autoregulation that occurs during anesthesia. So since we know, and when we know in our practical routine daily practice also, we see that this hypotension is quite common and it happens every day in majority of our patients, and it is definitely associated with adverse outcomes. So if we look at it, we have a lot of evidence also to tell us that this is happening. And if we look at this evidence, this is a very interesting article which was published in BJ in 2018, which was a review article, and they reviewed around 42 articles. This was by Wesley et al. And they study, there were basically 42 articles which were looking into the post-operative adverse outcomes at various mean arterial pressures. And what I found really interesting in this was they have said that a mean arterial pressure for less than 80 millimeters of mercury for more than 10 minutes was also associated with some kind of organ injury. It may not be a serious organ injury, but definitely some kind of organ injury was there. And I found that quite interesting because normally we do not aim to keep our mean arterial pressure so high, that is more than 80. Most of us target at around, between 60 to 70. So this was one thing which was highlighted in this review article, which I thought we should, really look into it more deeply. And obviously, yes, as the mean arterial pressures were less than 70 or less than 55 or less than 50, definitely even shorter durations in these was associated with adverse organ injury and as well as organ dysfunction. So then Salmasi et al. Again did a retrospective analysis. We have a lot of audits these days and a lot of retrospective analysis being done. And they thought, okay, because since the previous one was a review article and it did not really have a very standard definition of hypotension, because some anesthetists may have used the mean arterial, some may have used the systolic, some may have used change in the baseline, say from 15% or 20%. So they said, okay, let us see whether what is it that is important. Is it an absolute reduction in the mean arterial pressure that is important, or is it a change, a percentage change in the baseline that is important? And what they did was they also calculated a time weighted average. That is, they looked at it for how long the mean pressure was below, the baseline. And it was like, okay, if it was for 5 minutes or 10 minutes, and divided it by, multiplied it by the blood pressure at that time and divided it by the duration of surgery. And that is how they got the time weighted average. And what they found is, irrespective, whether you're using the mean arterial pressure of 65 or whether you look at a reference, baseline, both of them are equally representative, and both of them, baseline reduction of less than 20%, or whether you take a mean absolute value of less than 65, both of them are associated with post operative adverse outcomes and organ injury. And the other interesting thing that they concluded was that it had no relation to the preoperative blood pressure. So, as we further continue with this discussion on this intraoperative hypotension leading to post-operative adverse outcomes, Walsh et al. Found that a mean, if you had a mean arterial pressure of less than 55 millimeters of mercury, and they, did an observation, and what they found was that even graded it between for duration like 1 to 5 minutes, 5 to 1 minute, 1 to 5 minutes, 5 to 10 minutes, and more than 20 minutes. And there was a substantial increase in the risk of outcome as the each minute that elapsed when the patient was kept at a mean arterial pressure of less than 55 millimeters of mercury. So as we see in this graph, we can clearly see that as the pressures go below, as the mean arterial pressures keep dropping, the risk of developing any acute kidney injury or whether it is myocardial injury keeps on increasing. And to further on this, some of the anesthetists said that, okay, we know that intraop hypotension is giving us post-operative adverse outcomes. This was a group in France which said that, okay, let us use an individualized blood pressure strategy, not take a standard that less than, plus minus 20% of the baseline, or use an absolute value. And this was a very important study because it had focused, they chose 298 patients who are undergoing major abdominal surgery and who are already at high risk. There were those ASA3 patients who were definitely going to develop some kind of an organ injury afterwards if, when because of the kind of surgery and anesthesia that they were getting. And they used two strategies. One was an individualized strategy that was, to aim to keep the systolic blood pressure within 10% of the reference value. And the other was the standard that we use, that, okay, if the SBP goes less than 80, or, if varies from 20 or 40% of the baseline, we are going to treat it. And what they found was that, the primary outcome was obviously to see any organ dysfunction, whether it was kidney, respiratory, cardiovascular. And then the secondary outcomes were a 30-day all-cause mortality, the length of hospital stay and ICU stay. And if we see that, it was the organ injury which was there, it was there in 38%. It's actually quite a high number. 38% of patients who had been in the individualized strategy had some kind of a post-operative adverse outcome, compared to 51%. Although if you had an individualized strategy, the number was less. But if we see overall, yes, it was a much higher number. And when you look at the secondary outcomes also, 46% in the individualized group compared to 63% had some kind of post-operative organ dysfunction. So they concluded that yes, patients who are predominantly undergoing abdominal surgery, who are actually at increased post-operative risk, having some kind of an individualized blood pressure strategy compared with a standard management, reduce the risk of post-operative dysfunction. So it goes on to tell us that, as we say that, it is just it's not a number that we should aim or target for any patient. We need to look into the kind of surgery that he's undergoing, the kind of patient that what are the risks that he is going to have in the post-op, and then define a pre-op strategy so as to target that kind of blood pressure that we want to achieve. We should not, as we said, one size, as Sir just mentioned, one size fits all. That is not what is, going to give us good quality and good outcomes after anesthesia. And this was again a very interesting article which has been published by Staplefield. And what they have done is they've called it what is known as the SLUS score. They use the electronic, they had the electronic database system. And what they have done is that they have mapped, like from 1 lakh patients, they mapped at, how much time each patient spent between a range of, 45 to 75 millimeters of mercury. So they call those 31 thresholds. And they then mapped that, how much time each patient spent at that threshold, which they called it the hypotensive exposure times. And then these hypotensive exposure times, which they had got, they studied it on a development cohort of 35,000 patients. And they said that, okay, on these patients, they found that for how long were they spending time in that hypotensive exposure, exposure time, which they called it which were the limits which they set. And when they checked these limits and they found that how much time the patient had spent in this period, for how long, they calculated a score which they said is the St. Louis University score. And if you see that in this score, if they found an odds ratio that if the score was 0, that means the risk of the odds ratio of having any mortality or morbidity was much lower. But as the score kept on increasing, the risk of developing a post-operative adverse outcome went on increasing. And here we can clearly see in this red line that as the patients whose pressures were less than 45 and as they kept going below that threshold, the risk of mortality kept on increasing. And another thing that they found was that the hypertensive patients were more prone to develop, the adverse outcome as compared to those who were normotensive. And when they studied this score on a prospective cohort, they found that as the score keeps on increasing, the 30-day mortality, whether you look at the various other syndromes like organ dysfunction or septic shock, everything kept on rising. So what we have seen so far is that we have always been, when we have a patient and we are monitoring him, then we have been reactive. Like, the patient's blood pressure drops, then you look at it, then you look at the various causes as to why the pressure has dropped, and then you treat it. After a few, now what has happened is this is what we used to be doing in the, last few years. But over the last 2-3 years, with the development of the dynamic variables and all, we have become proactive. That is, we see that there is a stroke volume variation or a pulse pressure variation occurring. And when we, treat it or we treat the other causes of it, we are, preventing the hypotension from occurring and prevent that, okay, once we treat it, the hypotension will not occur. But I think the time is to be predictive. We don't have to wait for the hypotension to occur, or we in fact have to predict that, yes, this is going to occur, and we need to take actions before that so that the hypotension does not develop and we can give much better outcomes to our patients. And this is what I think the future in anesthesia is going to be, and this is where the role of artificial intelligence comes in. So what we have in this is that basically what has been developed in the last decade is machine learning. Machine learning is nothing but a subset of artificial intelligence, which enables systems to use the data which it has collected and learns from experience, and it does not require any explicit programming, like how the flow track and the Vigilio and all these monitors, and then the other monitors that we use like the QNOX or the QCon, that is how they have been developed. They have data fed in from a lot of patients, then the machine studies those data, the inputs are put, and we've seen that as each generation is increasing, we have added more and more skill sets and experience into it, and they are becoming finer and much better. So this is what we are already using in anesthesia, to measure like the depth of hypnosis. We use the BIS, the Q-con, or the, QNOX. Similarly, all our advanced hemodynamic monitors, they are basically a part of this machine learning only, or artificial intelligence, which is being used into daily practice with us these days. And this, along with demand modeling, has reduced the percentage of errors and improved our accuracy. So can we predict impending hypotension? Yes, with the help of AI and machine learning, definitely we will be able to do that also. And work on this had started quite a few years back. This is a article which was published, I think, around in 2010, which was in investigation of patterns or changes in the hemodynamics of patients in the ICU. And they found that yes, there is definitely a pattern which exists. It is just we need to identify this pattern in the hemodynamic data, and this data, which when interpreted by a machine or with the help of artificial intelligence, is going to indicate that there is some kind of hypotension that is going to occur. But after that, the work did not occur much in this field. It was only finally by Hatib et al. When this machine learning algorithm came into place, in which Hatib et al. Actually took a retrospective cohort of 1,334 patients, and he recorded the arterial waveforms in that. And from that, he picked up the machine picked up a few points. See, what happens is that to the normal eye or to the human eye, we cannot observe very minute changes that occur in the arterial waveform, which are because obviously the human eye is not trained to pick up those, and we also cannot continuously monitor those subtle changes. And plus, the body is continuously trying to play a compensatory mechanism. So our renin aldosterone system and everything gets activated the moment we know that hypotension or something is going to happen. So we as humans cannot pick up those subtle changes which are happening. So this machine is able to detect those small changes, and what they have done is that they were able to identify around 51 points which were changes in the arterial waveform which occurred. And then with those 51 points which were picked up, with the machine made a combination of more than 2 lakh parameters. And when that algorithm was put in place, they were able to say that yes, we can predict hypotension, and that is how this new indicator is now available to us. So this is basically a machine learning algorithm which is based on thousands of arterial waveforms, and it can identify an intraoperative hypotensive event 15 minutes before its occurrence with a sensitivity of 88% and a specificity of 87%. This was the work which was done by Faraz Hatib, and it is known as the Hypotension Prediction Index. So what it is basically doing is that before the actual event occurs, for us, what happens is the actual event has already occurred. Before it actually we can see it, there are some certain physiological changes which have occurred, and then the parameter changes, and after the parameter changes, we notice it, and it is only after that that we can actually start the treatment. So we can say a lot of time has already elapsed before the actual event has already occurred. So this landmark study by Hatib et al. Shows the potential use of artificial intelligence for analyzing and predicting the cardiovascular hemodynamics, which he called the Hypotension Prediction Index. So I just said that it basically divided the arterial waveform into an a systolic phase, a diastolic phase, a systolic rise phase, a systolic decay phase, and then an overall decay phase, from which 3,000 individual features which were picked up. From there, 51 were the ones which they considered important, and that was combined, and it came to 26 lakhs of waveform features. And this, when it was put into the machine, and with the help of AI, a final predictive model was developed. And if we look into this, there is actually a linear relationship between the episode happening and the time being elapsed. That is, if we look at the range, and if we see that when an hypotensive episode is going to occur, it is almost linear, and there is hardly, like at 5 minutes, 10 minutes, and 15 minutes. And if we see, this is an illustration of record of one patient. By the time the patient developed hypotension, we see the hypotensive prediction index was already at 85, and it was telling us that okay, hypotension is going to happen. And within 15 minutes, the mean arterial pressure actually went down to around 60 millimeters of mercury. The limitations of this tool, as was put up by Hatib, was obviously it was developed to develop hypotension, that is a mean arterial pressure of less than 65 millimeters of mercury, lasting for more than 1 minute. So there is a gray, and more than 75 millimeters of mercury was considered as normotensive. So we have a gray zone between 65 to 75 millimeters of mercury. Secondly, obviously, it cannot, measure. It is not reliable when events like laparoscopic insufflation or liver manipulation. If all that vascular clamping occurs, so all these kind of parameters were not included in this study. Also, post-induction hypotension, which develops in most of our patients, was also not formally studied. And this was cohort algorithm which was developed. It was based on records of operating as well as critical care patients, but it was validated only in surgical patients. So as we see now I will just tell you what this hypotension prediction indicator or probability indicator is. That it is basically a unitless number, and it varies from 1 to 100. And if we see that higher the number, the closer the lesser the time it is, and it ways to predict the hypotension. So if here we can clearly see that by the time the blood pressure drops and we can start norepinephrine or anything else, the HPI has already increased 10 to 15 minutes before that, and telling us that yes, that hypotension is about to occur. And this was actually a review article which was published by Sogel, and they said that yes, it is a unitless number which varies from 0 to 100, and higher the number, higher is the probability, and shorter is the time for hypotension. And for each, as I've already mentioned it, for each data set, a period of hypotension of MAP less than 65 millimeters for 1 minute was what was studied in this group of patients. This value is calculated every 20 seconds, and it is displayed on the monitor, and it represents the probability that a patient will develop a hypotension, which is defined as MAP of less than 65, which will last for at least 1 minute. And this is done with the help of a sensor. It is like an arterial transducer, which is called the IQ or the Acumen IQ sensor. And this is how it looks on the monitor. We have a number which comes, and it is called a HPI parameter. And it provides us information. Once the value is more than 85, there is an audible alarm that comes up. And if for 2 consecutive times the upper limit is increased, there is a pop-up window which will come up, and along with that there will be a secondary screen, and it will prompt that okay, what are the changes in the hemodynamic variables like the preload and the afterload, and what could be the probable cause, and what are the treatment options that are available for us. So here we can clearly see that what would happen when you have a preemptive treatment for something, a reactive, and finally what we need to do when actually. So here there is a clear time delay between the change in the HPI and the drop in the mean arterial pressure. This is available from Edwards as a feature of EV1000 and Hemisphere clinical monitoring platforms. It was approved by the FDA in 2018. It is yet to launch in India. There are a lot of studies which are already published internationally on the use of this indicator. And one of this was by Ranusi et al. And they found, they actually studied it in patients who were undergoing major vascular surgery. And they found that, and what they used was a cutoff value of 55 and an HPI between 5 to 7 minutes. So in their study, the sensitivity as well as the positive predictive value was too low. But yes, if when they use the values of more than 98, then definitely the predictive value of this increased, and the positive predictive value increased to more than 64%. Similarly, Kendale et al. Used it in for patients who are developing hypotension after induction, And they found that this technique is useful in predicting post-induction hypotension also, and we can eventually in the future use it to predict post-induction hypotension too. Then Greenberg et al. Did a HYPE trial, which they did it to see where they compared, use this HPI along and compared it to the standard treatment that we use in all our patients. And in patients again undergoing non-cardiac surgery, the primary outcome was the time, the amount of time the patient spent in this hypotensive zone and the duration for which he remained in this period of hypotension. And what they found was that, and obviously they treated the hypotension depending on the cause, like if it was increase in the stroke volume variation with decrease in stroke volume, they gave fluids. If it was associated along with decrease in the arterial elastance, they treated it as a vasoplagia and gave inotropes. And if rest was normal and it was just a decrease in the stroke volume, most likely cause was impaired contractility. And what they found was that in the intervention group, the amount of time a patient was below the threshold of 65, it was just 0.1 compared to 0.44 in the control group. And the duration, the total time also which he spent in that danger zone was 8 minutes as compared to 32 minutes in the control group. Then Schneck et al. Studied it in patients undergoing total hip arthroplasty, where he divided it into 3 groups. The first group was one in whom he used HPI, compared it with the standard control, and this he compared with an historic control retrospectively to remove any bias that may have been there. And he found again that if we had this algorithm in place with a protocolized treatment, it reduced the incidence of hypotensive episodes in patients who were undergoing primary hip arthroplasty. And this was a study which was published by Davis et al. And they found that in 255 patients, the predictive, the sensitivity and specificity of using HPI to predict fall in pressures was almost in the range of 85% at 5 minutes, 81% for 10 minutes, and 80% at 15 minutes for a patient who was undergoing major vascular surgery. So just to summarize, I would like to say is that, the artificial intelligence and all these tools have been used not only in medicine, but to predict, for example, the butterfly effect actually came from, when the meteorology department was trying to predict a tornado, which was supposed to happen, say, 2 weeks later. And they found that the ripple of a particular butterfly was predicting that, a tornado is about to happen. So it was such a subtle change that nobody really noticed. But yes, when that was happening, they were able to say that, yes, a tornado is about to happen. So in chaos theory, that is what they say, that the butterfly effect is a very small change, which is in one state, which can result in large differences in a later stage. So, these are, if we put it into our practice, it is like a very small change in the, arterial waveform, which we are unable to pick up. But yes, if it is picked up on time, it is definitely going to predict the fall in pressure, which is going to happen much later. So it is extremely important for us to pick up that small change and do or intervene or, act as required, so that, the drop in blood pressure or, the hemodynamics does not get altered to cause any adverse outcome. Because there is so much of compensatory mechanism that is happening. It is, for the human eye, it is impossible to pick up those small changes. So, I would like to conclude by saying that what we have discussed so far, that we all know that intraoperative hypotension is common. It has far-reaching adverse outcomes, and prolonged periods of mild to moderate hypotension is as bad as a short period of severe hypotension. Till now, we have been following either a reactive or a proactive way, but it is time to be more predictive and use that kind of management for our patients. And I think Dr. Vinodhan just concluded it well, that these are all tools which are available to us, and we should not forget that we are the ones who our vigilance is what is more important as compared to any other tool that is available to us. So that comes foremost before any other tool that we use. It is just that we need to use all of it together to give better patient outcomes. Thank you.
Thank you, Dr. Sangeeta Khanna. That was a very wonderful talk. You highlighted the role of hypotension in adverse outcomes and the fact that we need to keep our blood pressure very much close to the sort of normal pre-op value throughout the surgery. And the fact that we can now predict hypotension using this new tool based on artificial intelligence, the Hypotension Prevention Index. And of course, the HPI also tells you whether it's because of a low preload or whether you should give fluid, whether you should give an inotrope if the DPDT is affected, or whether you should give a vasopressor if the elastance is dynamic elastance is affected. So I think it's a very good tool, but it's a tool, and ultimately we have to use our head to see what to do. So are there any? I don't see any questions on the chat for Dr. Sangeeta Khanna right now. So can I ask you, Dr. Khanna, is, let's say you're doing a case and the patient appears to be rock steady, but the HPI tells you that you're going to get hypotension in the next 15 minutes. So as an anesthetist, will you do what seems to be suggested, like, either give some fluid or start a vasopressor or something like that? So
No, I mean, I get your question. See, if a patient is, that's what I'm saying. I think it is just a tool. And if my patient is going rock steady, and if his mean arterial pressure, and I know that there is nothing that is really going to, unless, okay, he starts bleeding in the next 10 minutes, then there is nothing I can do. But if I don't predict, if I don't see anything that is going to really go wrong, or I don't see, then I don't think I'm just going to treat a number.
But yeah, so I think that's an important thing, that don't jump to treat, but maybe, you could look to see, is there something going wrong? Have I missed some bleeding? Has there been some slow ooze which I've sort of missed? Are there some subtle changes on the ECG? So it'll definitely prompt you to do something and investigate as to what could be happening, which may actually result in hypotension in the next few minutes. So I think that's a good point you made. You may not necessarily jump with a drug or fluid, but certainly you should look at what seems to be happening and just evaluate what's going on in the surgery at that point in time. So,
yes. Can I get in?
Yes, sir.
Yeah, as rightly concluded by Dr. Sangeeta, we cannot totally depend on this tool. We have to use our brain to manage the case. To give you an example, a few days back we had a refractory hypotension on the table in an ASA1 patient. So in that situation, it doesn't give the cause of hypotension. It might tell you what is there can be an hypotension because this case happened to be a case of anaphylaxis. On giving an antibiotic, patient developed hypotension, but we didn't know the cause because the patient was ASA1. So he responded only to adrenaline. So in such a situation, this becomes useless because it doesn't give you the cause and doesn't give you how to treat them or manage the patient. That is one drawback. Another one, when you are assuming something or predicting something, you cannot depend on that, because you have to. The reason I say this is because to get a value such as this, you need to have several data, because every patient is different. They have different comorbidities, and the fall in hypotension, fall in blood pressure can be different in different patients. So how effective would it be in using in the perioperative period? Dr. Sangeeta, you have rightly said that it is a tool and we cannot depend on this for managing patients.
Yes, I mean, I agree to that, but I think what this monitor, I think, is in addition going to do is that, once it, suppose, it says that it gives you that, okay, hypotension is about to happen, then it will give you, like it said, it will give you an audible alarm. Then if in the second consecutive reading also, suppose, the value still is persistently high, then it is going to prompt a window where, like we have these dynamic parameters, because it is again a tool, you based on the arterial waveform. So in combination, it is going to give us the other parameters also. It is going to tell us the stroke volume variation, the cardiac output, or what else, whatever we have want to take from it, the SVI or the SVR. So I think it will be a when we have the whole screen in front of us with all these things, then maybe it'll just tell us that, okay, all these things that are going wrong, then it is going to tell us that, okay, okay, then this is what we need to do, like if our SVR is low, so we need to use a vasoconstrictor, or our SVV is high, so we need to give fluids. So it is not just going to be this number which we are going to act on. It is that when we get this number which gets prompted, then we see the whole screen, we see the maybe we are using BIS or we are using MAC, maybe the depth is too much. So, it'll just give us an alert that, okay, something is maybe not right somewhere and we need to maybe look at it. And maybe even after looking at everything, we find that, okay, it's okay. We don't really need to jump to conclusions. So that is the only way I think maybe it will help us, or and maybe honestly, it is only after we use it we can really say that whether it is actually as beneficial or not.
So I think just to take your analogy forward, so you had this anaphylaxis, and over say 5 minutes the BP is going to start dropping. So the HPI will tell you first that the BP is going to drop in the next 5 to 10 minutes. It will tell you that your SVR is low, so your dynamic elastance will be low, and it will tell you that the patient may be fluid responsive. Now you still need to figure out why this is happening. You still need to know whether this is anaphylaxis or whether it's a high spinal or or whatever it may be.
Correct.
And it'll tell you what therapy to apply, like whether you need a vasopressor, you need a fluid, or whatever it may be. But you still need to figure out for yourself what is the actual reason why all this is happening. So you're right, it's a tool. Hopefully it will be a good tool, and hopefully not be a very expensive tool. But it doesn't take the human interface away at all.
Okay.
And I think for those who want to read more about this, there was a very nice article which we published in the Indian Journal of Anesthesia. Not we meaning, it's published in the Indian Journal of Anesthesia in the November 2019 issue. Okay, so it's by people who've done work on this field on predicting hypotension. So those who are interested can go back home and read about it. If you've not heard enough already, if you've not learned enough from Dr. Sangeeta Khanna's excellent talk.
Thank you.
So I think again is the same question on the chat, that do you suggest an intervention in all scenarios where the MAP draws below 65 if the cause is just induced hypotension during surgery? So I mean, I guess if you're inducing hypotension, you don't have to worry about it. This is where it's not induced by you and induced by something else surrounding the surgery. Right. But I think you made the point very nicely that a little hypotension, even for a short time, we tend to accept low BPs for some time. It's the usual thing. It happens a little after induction, little after epidural, no problem, doesn't matter, it'll come up. But in some patients, that little bit of hypotension persisting over even a few minutes can actually cause slightly long-term problems. So I think that's a very important point that was made in the talk. So I think if there are no further questions or comments, I'll hand over back to the organizers, Dr. Binil.
Thank you, sir.
Yes, Binil.
President is there. Nasa sir, please.
Okay, that was a wonderful session. We all really enjoyed that. Now, Binil, this program was sponsored by Edward Life Sciences. On behalf of Kerala State Chapter, I thank Edward Life Sciences for sponsoring today's speech. Thank you, Edward Life Sciences. Now, there are teachers like Dr. Mubarak and all that. If there is any comment, they can unmute and start. Binil, please unmute our seniors, teachers, please.
They can unmute themselves, sir. But our senior colleagues or participants can unmute by themselves and ask the questions.
Any comments or any clarifications from your side, Mubarak sir and all? Dr. Rajesh is there.
This COVID scenario has made the world smaller, and we have got wonderful speakers from across the country. So it was very nice to hear the topic by speakers from Kerala as well as from Haryana. And panelists and the judges or the chairperson from Mumbai and all. So it was very useful talk, and the current concepts of the intraoperative hemodynamics status. It was very useful. Thankful ISA for sponsoring and having such weekly programs. Thank you, Nasser.
Dr. Kameshwar Rao is there. Your comments, Kameshwar Rao, sir? Anything?
Good evening.
Good evening.
Hello.
Yes, sir. Good evening.
Good evening, sir. Very nice programs you are organizing. I'm very happy to see Dr. Divedia on the platform, and very happy to see all the seniors. And very useful programs you are conducting regularly every week. Very beneficial for the postgraduates. And the next week we are planning, I think, ASCII, which is a very important thing for all the postgraduates. And the selection of topics, and you are maintaining good high standard with good speakers, and I'm really happy, and should continue like that during this COVID time.
Thank you, sir. Thank you.
Dr. Chittora and others?
Yes. Good evening, everybody. Really, the topic of the hypotension prediction index is very nice, and it has enriched the knowledge of